I'm really happy to be here. My name is Sandra McAllis, and I'm here on behalf of the NB-POM team, which is a team that we had created as part of the Healthy Seniors Pilot Project funding, which is really focused on dementia and prevention of dementia. And one part of the project that I'm here to share with you guys today is about the incidence and prevalence of dementia, which we described over time and place in New Brunswick. And this was focused specifically on administrative data, and I'm happy to be here to share some of the results that we've generated so far. So as I mentioned, this is a sub-study of a larger study. So the NB-POM study, as I mentioned, funded through the Public Health Agency of Canada, Healthy Seniors Pilot Projects. The NB-POM project had 3 objectives. I was primarily responsible for leading the 3rd objective, which I'll talk about last. I'm just trying to move stuff on my screen so that it's easier for me to see. So the first 2 objectives were really aimed at informing on and using primary data collection approaches. The first was about engaging seniors and understanding how seniors wanted to learn about prevention for brain health related conditions like dementia. And we really used methods that were driven through patient engagement strategies because we had a group of patients who were leading that research. The second objective was based on research that had been piloted in other provinces or other countries and was aiming to be done in Canada. And actually, because of the HSPP funding, our team here in New Brunswick was able to be among the first to be able to do this. Of course, because of COVID, we had to switch gears. And so the program was a bit different than what has been tested in other places. But the key here is that behavioral interventions are found to be really effective of reducing brain progression changes with respect to dementia. And so identifying people at risk and then intervening on those individuals will help us to prevent dementia. And that was the goal of Objective 2. And as I mentioned, originally it was planned as an in-person study, but because of COVID, we switched gears and we then called it Synergic at Home. And so it was a virtual program that was provided, results of which are also forthcoming. And the 3rd objective, which I mentioned, I was the lead on, also with Pam Jarrett and Chris McGimmon. And this was really aimed at looking at evaluation and monitoring. And this is where the incidence and prevalence study comes in. We're really interested in understanding how dementia and dementia risk factors were distributed in the province to better inform on where should the programs that we were looking at in Objective 2 be targeted. Where is there more of a need of dementia in terms of dementia diagnoses, and then where is there more a need of dementia interventions in terms of risk factors. And so that was the goals of Objective 3. Today I'm talking about the incidence and prevalence study, and I was here, I forget when it was, but maybe in May, to talk about the risk factor study. And so that's on YouTube, I assume. So just to start off, I mean, everyone kind of has a sense of what dementia is, and we have somewhat of familiarity, but just to start off sort of on common ground. So what is dementia? Well, dementia is thought to be a neurodegenerative disease. So that's the disease that breaks down the cells that are in our brain. And so this is an important pathology because it results in a decline in cognitive ability. And this cognitive ability has to be severe enough to interfere with daily life. So, we have forgetfulness and that's okay. And with age, people, think that increases, but it's really important to distinguish dementia as not just having memory issues, but really the severity with respect to those activities that interfere with one's daily life. So symptoms include common things that we're familiar with: memory loss, confusion, but this also results in difficulty with communication and impaired judgment. So dementia, thankfully, in most people is a slow progressing disease with the symptoms worsening over time, but eventually it leads to affecting someone's ability to perform daily activities and oftentimes leading to dependency for most of those activities. So not only does this then impact the people living with dementia, but also their families and caregivers, and really at a societal level as well, because we have to ensure that we're able to care care for the individuals who have this diagnosis because they require that important care. So this requires long-term support, such as living in nursing homes. And so nursing homes are a common place for people with dementia, especially when they've progressed to a stage where they can't manage to live in the community no longer. But thankfully, research has shown that many of these cases could potentially be prevented through behavioral modification. And that was really the purpose of that second objective of the NB-POM study that I just explained. So this is a really famous study. It's called the Lancet Commission on Dementia Prevention. There's several of them. There's a more recent version. I didn't put it in the presentation because it's not open access, but this one is open access. The more recent version is just an update of this, and they've done these over the last bunch of years. But overall, what this suggests is that 40% of dementia prevalence is potentially modifiable. Early life factors are things that are defined as education. So more education leads to less risk of dementia. Once early life has passed, there's also modifications in mid and later life that are possible. And some of these include hearing loss, traumatic brain injury, hypertension, heavy drinking, and obesity. And we say midlife, it's about 45 to 64 years old. When we say late life, that's over the age of 65. And factors in late life associated with risk of dementia are smoking, depression, social isolation, physical inactivity, air pollution, and diabetes. I didn't put it here, but a more recent study has come out looking at a same population attributable risk approach in Canada. And actually they find that this percent of preventable dementia is actually a little bit higher than here. The assumptions that go into this type of approach are many, and so we just have to use it as an opportunity to learn about what we may be able to help in terms of dementia prevention. So now switching gears from dementia, which is one focus of this presentation, to the other focus was really on the incidence and prevalence over time and place, which is really about disease surveillance. So what is the purpose of these values or these estimates? Well, they really help us to describe the burden of disease and to be able to track trends over time, track trends over population characteristics, for example. By estimating incidence and identifying perhaps where there's an increasing incidence, we really may be able to identify early identification of at-risk populations. For prevalence, if we know where there are more cases of dementia in the province, then we're able to do better allocation of resources with respect to healthcare that is needed for people with dementia, or future planning, for example, with respect to nursing home development. Construction. Disease surveillance is also really important of public health practices. It helps support public health planning and policies, thinking about maybe where there a greater need for primary, secondary, and tertiary prevention activities. It also helps us with understanding disease progression, and both incidence and prevalence, especially incidence, is a very common measure that's used in epidemiological research to understand what are these risk factors. So those that I just described in the previous slide, linking those risk factors with the incidence of dementia is how we uncover what are the factors that may be predisposing people to having these diseases. So those were the purposes of disease surveillance, and now just some approaches. So two common approaches that are used are disease registries or case identification algorithms. So disease registries are typically based on primary data collection. So maybe the researcher might send out a survey to all neurologists, for example, or geriatricians across the country or across the province or across the region or the city or what have you, whatever region you'd want to estimate. And then you would identify who the cases are and then have some sense of where you pulled. Other options for disease registries without primary data collection is pulling them from EMRs. And one of the example here in Canada that we have of a dementia disease registry, they have other diseases as well, but is the Canadian Primary Sentinel Surveillance Network, or CPSN. And this is a network of primary care networks. And so across the country, and New Brunswick is not yet part of it, but we are in early discussions about potentially joining CPSN as well. Case identification algorithms is a more modern method to disease surveillance. And this is because we are able to use these large data sets that we have and repurpose them for the purposes of identifying people with dementia. So for example, people who go to hospital maybe have ICD codes that represent a dementia diagnosis in which we can identify identify cases, and then this can serve as a mechanism for disease surveillance. And this is what we do in this study and what we do here in the province of New Brunswick, and we use the Public Health Agency of Canada, Canadian Chronic Disease Surveillance System algorithms, and New Brunswick Department of Health reports up to PHAC, and these disease surveillance systems are in place to be able to track nationally as well as at the provincial level. I didn't put the link to the website, but Google it and they have a really nice data visualization tool that you can play with. So I talked about incidence and prevalence. So incidence rate, so just to give a sense so everyone knows what we're talking about when I present the results, incidence is the number of new cases of a disease in a specific population over a defined period of time. So really key here is new cases, a specific population over a specific period of time. So those are very important when we're talking about incidence rates. And this helps us to measure the risk of developing a disease and is often expressed in per person time, like how many person years or person months or person days. Oftentimes in the lay literature, you won't see that, but that's what's behind the scenes. It has an element of time to it. And that's the defined period that I specified in the definition in that first bullet. An incidence rate is essential for understanding disease trends and essential for guiding public health interventions because it's the measure of risk, and it's quite important in epidemiological research as well. So prevalence, I know it's often said prevalence rate, and I've crossed it out because it's not a rate. There's no time associated with prevalence estimates. Prevalence is a proportion. You can say it as a percentage, prevalence percent, if you multiply that proportion by 100, but it is not a rate. So if we can disseminate some knowledge to continue that, that would be great. So this is the prevalence is really the total number of people existing, the total number of people with the total number of existing cases of a disease in a population at a specific point in time. So we might choose a specific point, like today. What is the prevalence of dementia today? It's hard to get all the cases of dementia today, so we might extend that over a longer period to give us an opportunity to identify those cases during which we would call it a period prevalence estimate. And prevalence provides an estimate really of the burden or how widespread the disease is within a community or in a population. So we can estimate the prevalence across regions in New Brunswick or for the whole province, for example. And prevalence is really crucial for assessing the burden. Where do we need to target more resources that are needed for caring for the specific disease, and in this case, dementia? So just to give you a sense of what these look like in terms of their formula, so when we estimate them, the incidence is just the total number of new cases in a defined population over a defined period of time, and that total time at risk. So if we follow 100 people for 1 year, that's 100 person years in the denominator, and the number of people who got dementia, say 5 people, would give us a 5% or an incidence rate of 5 per person year. The prevalence, on the other hand, is the number of cases over the total population. So as you'll see, the time element is not considered. And so the prevalence is a true proportion. What number out of the total number are having the condition that we've defined? Standardizing estimates is another thing that I present here. So just to bring everyone up to speed on what I mean by that. So we need to standardize estimates mainly for the purposes of adjusting for differences in population structure. So I'm just looking at New Brunswick at this specific time, there's no need for standardization. But if I want to compare New Brunswick to somewhere else, or I want to compare New Brunswick today to last year or to next year or to any other time point, things change, right? So populations are getting older, so we need to account for that. As you get older, you're more likely to have dementia. So over time, we're going to expect higher rates of dementia, but is it because we have an older population, or is it because the rates aren't standardized, and so we're not comparing apples with apples? And standardization really provides us with that clear picture and removes the bias from specific factors, mainly demographic factors, but you can standardize for anything if you have the data. So it's really essential for comparing disease patterns across regions, as we'll talk about today, and across times, because there's different characteristics that need to be considered. And in addition to age and sex, the standardization can be done for factors that are really important for driving those differences. If they're not, then there's really no need for the standardization. And before I kind of get into the results, just wanted to connect the incidence and prevalence. So incidence and prevalence are connected in this way. So the prevalence is actually the incidence times time. So when you have a high prevalence, it might be either due to the fact that the disease is common, or that it has a long disease duration. So once you get it, you live for a long time. So we might have a high prevalence for two reasons. We might have a low prevalence because the disease is rare, or we might have a low prevalence because once you get it, you die. And so you won't, at any point in time, we won't have a lot of people. So there's this connection between the incidence and the prevalence. So if we have people with dementia living for a longer period of time because of interventions or supports that we have in place, this will translate into a higher prevalence of dementia as well. So this is important to also consider as a potential confounder. Right, so now about getting into the objectives of this specific study. So I mentioned that this objective was embedded in this NB-POM, and it was really aiming to support the scaling and the sustainability planning for brain health interventions. So where are these interventions needed most, and what resource, and where are resources directed best? So where is the burden highest with both risk factors for dementia, but also with the rates of dementia, people who are living with dementia? We wanted to understand what that burden of dementia risk was. Where is the burden greatest, and how is it changing over time? And helping us to understand the tools that we're using to be able to do this in New Brunswick. The specific objectives of this presentation for the results I'm going to show you today was to describe the incidence of dementia over time and across health regions, and to describe the prevalence of dementia over time and across health regions. So just getting into the data sources, all the data was accessed through NB-IRDT, so the New Brunswick Institute for Research Data and Training, and the data was accessed at the Secure Data Facility at UNB Fredericton. We submitted a data access request to access several data sets that allowed us to do this work. Two of those data sets that we used for this analysis were the citizen data, which is the Medicare registry data for the province, and the Canadian Chronic Disease Surveillance System data, which are algorithms developed by PHAC to monitor diseases in the province, across the provinces. And in New Brunswick, we applied this algorithm to the administrative data, and it allowed us to identify cases of dementia. We used the most recent 15 years of data that was available at the time of data analysis. The most recent fiscal year at that time was 2018-19. And the fiscal years were used and populations defined on April 1st. So our 2014-15 estimate doesn't represent a calendar year. We use fiscal years because the data are set up that way. It just was easier, and it shouldn't matter. So the formulas that I showed you of both incidence and prevalence had both numerators and denominators. And so just getting into what are those. So the denominator for us included all older adults over the age of 65 living in New Brunswick. And they were defined in this way by having an active Medicare card. So if you left the province, you were no longer in our sample. If you returned to the province and your Medicare was then active, you were then in our sample. We followed this cohort over 15 years from 2004-05 fiscal to 2018-19. And people were included in the analysis, as I mentioned, until they left New Brunswick or didn't have that active Medicare card, or they died, and at which time they were removed completely from the analysis. So the denominator for the instance, for every person that we identified over the age of 65 living in New Brunswick, they contributed 1 year each once they turned 65. So as people turned 65, they entered our cohort until they died. So if they were in our cohort for all 15 years, they would have 15 person years. And so that was the denominator. And we summed the denominators over all the people in our cohort. And that was our denominator for our incidence rate. For prevalence, we estimated the number of people who were over the age of 65 and alive at the midpoint of that year. The numerator, we use the Canadian Chronic Disease Surveillance System dementia algorithm, as I mentioned. The CCDSS has many different categories. Neurological conditions is one of them. Within neurological conditions, dementia, including Alzheimer's disease, is defined as one. Others are multiple sclerosis, Parkinson's, for example. The CCDSS also has respiratory, cardiovascular, many other conditions that may be of interest to you. So the case definition specifically for the dementia algorithm was one or more hospital separations. So they had to be discharged from the hospital one or more times, or they had to have 3 or more doctor's visits within a 2-year period that were at least 30 days apart, or one prescription drug or more. That doesn't read well, but anyways, so this is the case definition for the Public Health Agency of Canada algorithm. In New Brunswick, we have not applied this last criteria. So the 2 first criteria are what are included in this data that I'm presenting to you today. So as I mentioned, we're looking over time and place. So we use several different approaches to stratifying the incidence and prevalence estimates. So over time, we looked at annual estimates. So each year, what is the incidence and prevalence of dementia? We also grouped years we grouped them into 5-year periods. So we had 3 5-year periods over the 15 years. So over place, we were also interested in understanding where the distribution of dementia may be greater in the province. And so we looked at 7 health regions. Standardization was used, as I mentioned, to allow that comparison across time and across health regions. Incidence and prevalence were both age and sex standardized. The estimates that you find on the Public Health Agency of Canada website, that data visualization tool that I told you about, are not sex standardized, but age standardized. So our estimates may differ a bit from those. And we use the most recent year of data we had in the study as the standard population in which to standardize the estimates. So all our estimates are compared to the population of 2018, which was the most recent year. So this is what we found for the standardized dementia incidence over time. So the average about 12 to 1900 new dementia cases annually were found based on this incidence rate. Over a 5-year period, it was approximately 6,400 cases in the first period, whereas in the last 5-year period, this was over 9,100 cases. The crude rates were very similar. Whereas the standardized rates suggest an increased 1.6% increased rate over time. With respect to prevalence, the standardized prevalence of dementia over time, the number of individuals living with dementia in each year ranged from about 5,300 in the earlier years to about 8,900 in the later years. So over this 5-year period, there were approximately 8,300 individuals in that first period, but almost 12,000 in the most recent period. And remember, prevalence adds up all those people, so the number is quite much larger than the incidence number that you saw. And so the crude rates were very similar as the denominator increased, and standardized rates suggest a 1.1 increase in prevalence over time. So this is what we found with respect to the regional distribution of dementia incidence. So the graphs here give us the incidence on the y-axis, and then each of the 7 health regions are represented down here. So each of the graphs are just giving you the sense of the 5-year period. What we see in the first time period is we see a very large discrepancy across the prevalence of, or the incidence of dementia across health regions. There's a lot of difference. So we find that, in fact, the Fredericton region has quite a higher prevalence, or sorry, incidence of dementia than, for example, Bathurst, Miramichi, or Moncton. And we thought this was quite curious when we first saw these results. As we follow over time, we find that this is, in fact, getting much more homogeneous with respect to the different health regions. So over time, we observe a really leveling of incidence across health regions. And we'll talk more about why we think this is happening. The same thing we saw with respect to prevalence. So over time, we observed less overlap in prevalence across health regions, but also some leveling of the burden across health regions. This is also really kind of representing that the data that may have been collected in earlier periods using this methodology may not be as reliable as, for example, in more recent periods. So just providing an overall summary, I hope I'm okay for time. So the incidence and prevalence of dementia appeared to be increasing over time when we first looked at these results. But when we started to think about what was happening and what might be driving some of this change over time, especially with respect to the regional differences, we thought that this might actually be more likely due to methodological factors in finding these cases using case algorithms from billings claims than to act and to changes in clinical care and the diagnosis of dementia over time, rather than true increases in incidence and prevalence. So over this time period, billing claims data may have improved. The identification of dementia, the introduction of dementia care, dementia treatment in the province, all are throughout this period. The introduction of new geriatricians to the province, or neurologists, for example, in Fredericton and Moncton over these time periods, and perhaps more of a stable effect in the St. John region, which we know has been, because of Pam Jarrett and her work in Horizon, has been doing a lot of dementia care for quite a lot longer. So the need for dementia diagnosis is often, historically at least, been done at that specialty level. And so with that, we think that that might be what is in fact driving what we're seeing. With dementia not being as commonly recognized in the earlier periods of our data, that might also be why we're not seeing those in claims data. So this is what we're thinking is likely driving these effects that we've observed. So we think that then estimates that are obtained in the more recent time periods may be expected to be more reliable, but we need more time to better understand dementia risk and burden in the province, and to see how this progresses as we pass more time. We are also interested in doing improvements to these case identification algorithms to ensure the robustness of our study findings. I don't know if I tell it, but we did do a validation study. I may have mentioned it in a few slides, but just in case I didn't, we also have done a validation study using some data from Horizon Health that identified clinically confirmed cases of dementia and compared it to this algorithm. But as I mentioned, we have more confidence in the duration of that algorithm for the St. John region. So it will be very interesting for us to be able to do similar validation studies across the province to better understand how this algorithm is or isn't working in other places. So just a bit of discussion. I did mention that we think that what we're seeing in terms of dementia incidence increases in the province over time are due to methodological reasons, but we are expecting, based on our population and changes in population demographics, to have increased number of dementia. So what they're suggesting or projecting is the number of older adults living with dementia is expected to triple by 2050. So these are estimates that were created, I think, in 2019 or around there. So based on our numbers here, what we got in this study, and just know that, they might not be, based on what we've said already, but they're likely a good estimate for what we can get in the province. So we think that right now there's 9,000 cases, or not right now, but in that year there. And so by 2050, we expect that to triple. So we're almost at 30,000 cases of dementia in New Brunswick, that is. And the prevalence of dementia risk factors that are linked to a dementia diagnosis might also be increasing. So I mentioned that study that I presented a few months ago for DHKT. And what we found was, using Canadian Community Health Survey data, that in at-risk populations, that over time, these might be increasing: obesity, diabetes, hypertension, and we found decreasing levels of inactivity. So this might increase the potential for earlier diagnoses. We are finding that there are more early onset diagnosis. I know Ludovine Witowski at Dumont in Moncton is very interested in early onset dementia. And so this may provide an additional burden to the system, which we're not necessarily expecting. Earlier diagnosis with a long average duration, of course, is going to lead to increases in prevalence, as I mentioned at the beginning. So incidence and prevalence are tied in this way. So if we're helping people with dementia live longer, better lives, then we will in turn end up with higher incidences over time. But we really need to focus our attention on prevention. As I mentioned, about 40% of dementia is suggested to be preventable, or 40% of cases of dementia are suggested to be preventable. So we need to really focus on prevention and innovative resource planning, because it's really expensive to care for people with dementia. And so we need to be intuitive to be able to identify ways that we might be able to do this in more innovative approaches. So just some strengths and limitations. Of course, the strengths is we use population-based sources. We didn't have to go to clinics to identify cases. That would be a lot of work, so it was easier. But of course, there's limitations with some of these population-based sources, which I'll talk about in the next part of this slide. So we did use a previously validated algorithm. So this dementia algorithm has been validated in Ontario, and I can't remember one other place. We standardize estimates, which is really important about comparing over time and place. And we had the ability to just explore trends over time and place in the same analysis. So that was a real benefit to this work. Limitations, of course, we don't know if the person had dementia, and we don't know if we're not finding people who don't have dementia. And based on our validation, we know that that's true. And we don't have a clinical confirmation in the case identification algorithm. So we're not sure. We don't use prescription data to define the algorithm, but we feel that that may have a minimal effect based on all the other data that we have to capture this population. And limited access to treatments for dementia and to clinicians with expertise to diagnose dementia is what we feel may have been limiting the estimation of some of these disease prevalence, disease surveillance estimates earlier in the time periods. So other work and potential next steps. So I mentioned other work that we've done or are hoping to do more of is dementia validation algorithm. So comparing Horizon Health clinical confirmation of dementia diagnosis to the cases we found in the CCDSS algorithm. We're also describing healthcare utilization and quality care indicators in the years surrounding the dementia diagnosis. And this is being done in collaboration with partners at Horizon Health and the Canadian Consortium on Neurodegeneration and Aging. And we're really wanting to explore the impact of prescription drug data on estimation of the incidence and prevalence. It's not currently included in the algorithm, but now it is data that we have at NB-IRDT and have recently received. So it's possible to be able to extend the algorithm to look at this additional impacts. I just want to end off by acknowledging all the supporters and funding partners. So as I mentioned, NB-POM was primarily funded through the Healthy Seniors Pilot Projects. Of course, my role is affiliated with the New Brunswick Institute for Research, Data and Training at UNB, which is primarily funded through CIHR and MSSU, Research NB, and of course the Government of New Brunswick.